Welcome back to the Gulf Amyloidosis Club. My name is Firas Al-Badareen. I'm a cardiologist and I'm at Cleveland Clinic Abu Dhabi, and I'm the head of the imaging working group. I would like to welcome you back to this interesting series discussing the latest and greatest about literature on cardiac amyloidosis, diagnosis, and treatment. We've been on a break for the holidays and the holy month of Ramadan, and it is my great pleasure to resume this series now with a close friend and a colleague who will discuss something hot off the press about the diagnosis of cardiac amyloidosis. It's my pleasure to introduce Dr. Ammar Chowdhury from King Faisal Specialist Hospital and Research Center in Jeddah in Kingdom of Saudi Arabia, where he practices as a consultant, advanced heart failure, and in echocardiography. Ammar has special interest in cardiac amyloidosis, and he was able to identify this article that is really going to change the way we diagnose ATTR cardiomyopathy. So, Ammar, without further ado, I'll turn it over to you.
Yes, thank you, Firas. I think I lost my connection for a second there. Let me just share my slides again. All right, you can hear me well and see my slides?
I hear you okay, yeah.
Okay, all right, perfect, excellent. So yeah, thank you for this opportunity to discuss this study entitled Diagnostic Performance and Interpreter Experience of 1 hour versus 3 hour technetium HMDP cardiac amyloid radionuclide imaging, a prospective blinded comparison. So the study was published recently in Circulation Cardiovascular Imaging 2026. It's authored by Gregorio Tresalvi et al. The corresponding author is Umar Abu Azadin from the Mayo Clinic. I'll go over the background. So around 10 years ago, there was a major landmark study published in Circulation as well, which validated the use of radionuclide imaging for the non-invasive or non-biopsy diagnosis of transthyretin amyloidosis in the absence, of course, of monoclonal proteins. Now, this study allowed the use of 3 tracers, DPD, PYP, and HMDP. Eventually, PYP became the predominant tracer that was used outside of Europe. Part of that was prior regulatory approval was already available for PYP. And then with time, and more recently in the past couple of years, there have been some interruptions in the availability and access to PYP. So many labs in North America have switched to HMDP. Now, as you can see in the landmark study, out of a total of 1,200 patients, only 144, or around 12%, underwent testing with HMDP. And within the subgroup of patients that underwent endomyocardial biopsy, and there were about 370 of those, only 21 or 6% of patients were tested with HMDP. So given the greater utilization of HMDP in the last couple of years, there's been a renewed interest in testing the diagnostic performance of this nuclear agent. In that same landmark study, the protocol for imaging required whole body planar imaging to be acquired 3 hours after injecting the nuclear agent. And the idea behind that was to allow for washout of the blood pool, because earlier imaging would result in contamination by the blood pool. So if you delay the imaging, allow for the washout, and if there is uptake in the myocardium, we'd be more confident that this uptake is a true positive uptake coming from the myocardium rather than the blood pool. There was an exemption that allowed for 1 hour imaging for PYP. And that was advantageous for PYP because 3-hour imaging is not particularly practical, especially in busy nuclear cardiology labs. So investigators wanted to formally test the theory whether 1-hour imaging with PYP is comparable to 3-hour imaging, and they were able to demonstrate that in at least 2 studies using planar and SPECT imaging. And this was also reflected in the multi-society, multimodality imaging guidelines that were published in 2021, which recommended to use 2 or 3-hour post-injection imaging for all 3 nuclear tracers, but they provided the option of 1-hour image acquisition with PYP. What happened on the ground is that many labs had switched from PYP to HMDP and adopted the 1-hour imaging protocol despite the lack of rigorous evidence to support this practice. There's also a physiologic advantage that supported the use of earlier imaging with HMDP. HMDP undergoes faster blood pool clearance compared to PYP. So if you wait for 3 hours, there could potentially be loss of signal in the myocardium due to earlier washout that would reduce the sensitivity of the test. And if you move to an earlier imaging protocol at 1 hour, for example, you would pay the price of greater contamination with the blood pool, but you would also gain the advantage by compensating or mitigating the loss of sensitivity that might happen at 3 hours. And then you can potentially address the issue of blood pool contamination by using SPECT as opposed to planar imaging only, and furthermore by enhancing your imaging technique by hybrid SPECT CT, which further delineates myocardial uptake from blood pool uptake. So the rationale behind the study was, number one, to address the lack of evidence for imaging with HMDP at the 1-hour time point. Number two, the physiological support for earlier imaging with HMDP and to see if that pans out. And number three, to see if performance at 1 hour was comparable to 3 hour, since that would improve patient flow dynamics and patient experience in busy nuclear cardiology labs. So investigators at the Mayo Clinic assessed consecutive patients that were suspected with transthyretin cardiac amyloidosis. These were not cases that were confirmed, but suspected and referred for further analysis. All of these subjects who consented for the study underwent a 1 hour plus a 3-hour HMDP imaging protocol with SPECT and Fusion CT between the months of October 2024 and January 2025. They were then prospectively evaluated. And per the clinical practice at the Mayo Clinic, planar imaging was not performed. Investigators collected various other relevant data, including demographics, comorbidities, laboratory data, echo, and they calculated the Mayo Clinic ATTR cardiomyopathy score. In terms of scan interpretation, they ensured that the scans were anonymized, concealed patient identity and time points from the readers. These scans were independently analyzed by 2 expert teams and a 3rd arbitration team. Each of these teams consisted of 1 nuclear cardiologist and 1 nuclear radiologist. So there were a total of 6 expert readers involved in the study. They all analyzed the SPECT data first, and then analyzed the SPECT CT fusion images on an as-needed basis. And then they collected data with respect to these points on a standardized survey form. These points included overall interpretation result, whether the study was positive, negative, or equivocal. They graded them according to the Perugini grade, grade 0, no uptake, 1 less than the bone, 2 equal to the bone, and 3 greater than the bone. They measured the confidence of the readers in a dichotomized fashion, confident versus not confident about the result. They measured the need for CT fusion imaging. They flagged these scans for difficulty, and they also calculated a 3D score. The 3D score is actually a patented quantitative analysis of uptake. So what the readers or nuclear technologists would do is that they would delineate an area of interest in the LV myocardium and also identify a volume of interest in the right atrium blood pool to calculate the ratio of LV mean uptake in comparison to the RA mean uptake. And the lower the ratio, the lower the discrimination between the blood pool and myocardium uptake. Statistical analysis was done using various statistical techniques that were appropriate for continuous variables, categorical variables, statistical techniques that allowed comparison between the 1 hour and 3 hour uptake, and also to assess agreement between the different readers. So this is the patient flow diagram. There were 122 patients that were assessed for eligibility. 8 were excluded because they declined participation. 114 patients who were included in the study. All of these patients underwent imaging at the 1 hour mark and the 3 hour mark after injecting HMDP. So there were a total of 228 scans that were equally distributed between the two groups. In terms of the baseline characteristics, the average age of the population was 74 years. This is expected of the transthyretin amyloid population, or the population that was referred for suspected ATTR. However, to put things into more perspective, if you look at some of the recent clinical trials that were done for patients with confirmed transthyretin amyloidosis, the average age was 77 years as opposed to 74. 74 is sort of more in keeping with your garden variety HFpEF population. The recently concluded vutrisiran trial, Helios-B, and also the acoramidis trial attribute the average age was 77 because those trials were more enriched with patients who had wild-type ATTR. And similarly, if you look at the representation of male gender, it was 77%, whereas in clinical trials of confirmed ATTR, wild-type ATTR accounted for 90%, and men accounted for 90% of the population. If you look at the comorbidities, 40% obesity, hypertension was 45%. Again, these figures are somewhat in keeping with patients that have garden variety HFpEF. The investigators did not report NYHA functional class or symptom burden, but they did report NT-proBNP values, and the median proBNP value was 640, which is modestly elevated. Once again, if you compare this with clinical trials of patients that had confirmed transthyretin amyloidosis, in those studies, the NT-proBNP values were much higher. In the ATTRACT trial, it was 3,000. In the more recent vutrisiran trial, it was 2,000. So this is a population that probably was not very much enriched with ATTR cardiomyopathy. Majority of these patients probably had garden variety HFpEF. They probably also included patients with earlier onset ATTR cardiomyopathy. And that's also reflected in the type of cardiac remodeling. If you look at wall thickness, it was not really on average increased. It was upper normal. The relative wall thickness was also upper normal. The proportion of patients that had an ATTR cardiomyopathy score of 6 and above was 41%. This score is highly sensitive, but not very specific, and it's biased by and heavily weighted by age and male gender. The proportion of patients that ended up having confirmed transthyretin amyloidosis was 23%. So it's a population where the vast majority of patients at the end of this analysis did not actually have transthyretin amyloidosis. So in terms of the agreement between the two teams that analyzed the 1 hour and the 3 hour scans, for the vast majority of scans, there was good agreement. But there were cases of discordance in terms of overall interpretation, the Perugini grade. There were some scans that were difficult to read, and numerically, there were more of those at the 3 hour mark compared to the 1 hour mark. So these type of scans required arbitration by the third team. This is an example, a representative example of a patient that underwent SPECT at 1 hour, demonstrating uptake in the myocardium, but also possibly blood pool. And by combining this with CT, you can localize the uptake to the myocardium with a higher degree of confidence. So in terms of the results pertaining to the imaging part, first of all, there was high inter-reader agreement between the two teams when it came to the overall interpretation and the Perugini grade. They used various statistical techniques for that, and the Cohen-Kappa, for example, value was more than 0.8, which is consistent with very high degree of agreement. In terms of concordance, result-wise, there was a high degree of concordance. So if you look at the overall interpretation, the proportion of patients that had a positive scan at the 1 hour mark and the 3 hour mark was equal. There was a slight difference numerically in terms of the negative scans, but it did not reach statistical significance. In terms of the Perugini grade, again, there was a slight numerical difference in terms of grade 0 uptake, but it did not reach statistical significance. There were some numerical differences in terms of grade 2 and 3, but these are not clinically relevant because, as we know, grade 2 and 3 are considered positive scans. However, there was a higher number of patients at the 1 hour mark that had grade 3 uptake, and some of these by the 3 hour mark had grade 2 uptake. And this is expected because there will be some washout. There was one patient that had grade 2 uptake who ended up having grade 1 uptake at the 3 hour mark. Overall confidence was very high between the two groups. But the more important difference is that the 1 hour mark required greater use of CT fusion imaging to reach their conclusion. That's not surprising because there is greater blood pool contamination. So 57% of the scans at the 1 hour mark require CT fusion for appropriate interpretation versus 31% at the 3 hour mark, and this difference was statistically significant. As I pointed out earlier, numerically at least, there was a higher number of scans that were difficult to read at the 3 hour mark versus 1 hour mark. And the overall image quality was deemed high in both groups. Now, there's another important point to note here, and that is in terms of the equivocal scans, at the 3 hour mark, there were 3 scans that were equivocal, even though at the 1 hour mark, they were negative. So it's very rare, but in some of these occasions, scans that were initially negative became slightly positive or equivocal at the 3 hour mark. And all these 3 patients had clinically relevant disease. One of them, for example, had lymphoplasmacytic lymphoma on endomyocardial biopsy. Another patient had hereditary lysozyme amyloid on endomyocardial biopsy. And the third patient had coronary artery disease, and they did not undergo endomyocardial biopsy. So what you can see is that there is some discrepancies here So on some occasions, you can basically have zero uptake at the 1 hour mark, and some degree of uptake at the 3 hour mark. In other instances, you may have higher degree of uptake at the 1 hour mark and greater washout. That's the overall trend. That's what you typically see, but that's not always the case. In terms of the 3D scores, basically just to summarize this, the 3D score calculates the ratio between myocardial uptake and blood pool uptake in the right atrium. And the smaller the ratio, the lower the discrimination between blood pool and myocardial uptake. And these ratios were smaller at the 1 hour mark, which is again expected. So in summary of these findings, the 1 hour versus 3 hour protocol basically demonstrated high inter-reader agreement and concordance in terms of overall interpretation and Perugini grade, high image quality and interpreter confidence at both the 1 hour and 3 hour mark. There was a higher use of CT fusion imaging at the 1 hour mark, and this correlated with the lower 3D score at the 1 hour mark, which suggested inferior contrast resolution. Numerically, there was a higher need for arbitration at the 3 hour mark, and on rare occasions, negative reads at 1 hour turned equivocal at the 3 hour mark. Now, if we look at some of the elements of internal and external validation, this was a well-conducted study. It was prospective, blinded, with independent expert readers that allowed for a robust head-to-head comparison of the 1 hour versus 3 hour time points, minimized interpatient variability, and provided consistent adjudication. It was nevertheless a single-center study, so it was predisposed to selection and referral bias that can inflate positive predictive value. Planar imaging was not performed, which challenges the current guidelines. The patient sample was more typical of garden variety HFpEF. It was not particularly enriched with confirmed ATTR, and variant ATTR was underrepresented. There was only one subject with variant ATTR, and some of these subjects, as we know, in variant ATTR may demonstrate lower degrees of uptake with respect to the nuclear tracer. There's lack of gold standard testing in discordant cases with endomyocardial biopsy. It wasn't mandated. It was up to the investigators to do the endomyocardial biopsy when required. There was a large group of experts involved, a total of 6, so that could limit generalizability to non-expert centers. There was a higher utilization of CT fusion imaging at the 1 hour mark, so these results are not applicable to centers that don't use CT fusion imaging. And the study did not address the question of the 2 hour time point. So in conclusion, the diagnostic performance of the 1 hour post-HMDP injection is comparable to 3 hours. In other words, either the 1 or 3 hour time points are both, highly accurate. The incorporation of CT fusion imaging at 1 hour is required to achieve the same diagnostic accuracy at 3 hours, and therefore the availability of hybrid CT is a prerequisite. Can we, however, say that either of these protocols is superior? I don't think the study necessarily answers that question. It just shows that they're very comparable, but there are some trade-offs with respect to the 1 hour versus 3 hour mark. Is the study overestimating real-world performance? It's certainly possible, given the setup in which the study was performed, which was very specialized. What about the role of 1 hour mark in terms of early disease detection and subjects with variant ATTR? It's not entirely clear from this study. Another point is whether planar imaging is no longer required, and I think what the study shows is probably that is true. And this recommendation, which is in the guidelines, perhaps should be addressed in future iterations. All right, I'll stop here.
Thank you so much. Thank you so much, Ammar. That was absolutely elegant and detail-oriented presentation. And if you really managed to bring out the strengths and the areas that require further discussion in this study. Let me start off by asking you, there is no doubt that the availability of radionuclide imaging for cardiac amyloid has really revolutionized the field and enabled non-biopsy diagnosis. The problem is there are so many variables in the technique that have not been fully standardized. Is it planar? Is it SPECT or SPECT-CT? I know the guidelines clearly recommend the use of SPECT and SPECT-CT whenever possible, but there are still centers that perform planar imaging. The tracer, is it PYP, is it DPD, is it HMDP, which one? Imaging at 1 hour, 3 hour, both. And then the Perugini score itself. What is the value of, you just said that grade 2 and grade 3 are sufficient to make a diagnosis, but why do we still need a grading system? Why can't we just say positive or negative? So I think this has really moved the field of cardiac amyloidosis forward, but there are several areas that require further clarification. What are your thoughts on that area?
Yeah, I mean, to your point, I was actually surprised somewhat when I saw that numerically and statistically, the agreement between the experts involved here. There are like 2 separate expert teams. Each one was comprised of 2, individuals with more than 10 years of experience each, and still you had 33 unique patients out of 114 that required arbitration by 13. And we're talking about Mayo Clinic. So this really showcases what you're actually saying, that there is a lot of variability, and the consequences are quite significant. And especially when you look into the gray areas. And I think the grading has to be there just to give you that quantitative sense of how confident you are. Rather than dichotomizing them into positive or negatives, you need to get that feel of how confident the reader is in terms of the degree of uptake and whatnot. And there are many, techniques that are being used for the purpose of quantification, which is beyond the scope of our discussion. But I think the more data we have, it's a double-edged sword, really. The more data we have, the more variables, the greater the subjectivity, but also you have more information that you can use to your advantage if you really understand the data. So I think time will tell how we can refine all this.
Yeah, absolutely. If we try to bring this point home, the PYP MENA, that you were part of, the survey, the assessment of cardiac amyloid imaging techniques in the Middle East and North Africa region showed that PYP remains the most commonly used tracer. I think there was a center from North Africa that used the DPD, but otherwise PYP was overwhelmingly the most commonly used. So given that this study was with HMDP and showed that 1 hour imaging is sufficient to and equivalent to 3 hours, do you think we can extrapolate this to our centers here in the Middle East and the Gulf region, where PYP is the predominantly used tracer?
Yes, in fact, there were 2 studies that were done with PYP, which basically demonstrated the sort of equivalence of or comparability of the 1 hour versus 3 hour protocol. And these studies predated the society multimodality imaging guidelines that were published in 2021. These studies were performed towards the end of 2019, 2020. CT fusion imaging was not part of those studies at that point. They were relying on planar and SPECT imaging. The study design was not as robust as the study that we talked about, but the overall elements of those studies were quite similar, and so they already showed that the 1 hour protocol with PYP is comparable to the 3 hour protocol, even without CT fusion. With this additional data point, I think it just cements this concept that 1 hour imaging is, appropriate for both HMDP and PYP.
Excellent. Ammar, there is a question from the audience about, and I don't know the answer. Did they mention anything about the prevalence of aortic stenosis? I don't know if that was part of the Mayo Clinic study.
No, they did not look at that at all. Yeah.
That's what I thought. Okay. Okay. Question: was there any statistical correlation between the diagnosis of amyloid and the presence of aortic stenosis? We just said that the study did not include these data to answer that kind of question. I don't know if Dr. Smiley is with us yet or not. If not, we can carry on with this conversation. Okay. Ammar, what is your, when you go back tomorrow to your nuclear laboratory, what changes to your practice are you going to implement based on this study?
Yeah, so for full disclosure, I'm a heart failure cardiologist, and I do, run the cardiomyopathy clinic, but I obviously interact, on a daily basis with our colleagues in echo and nuclear, and our nuclear radiologist. There's been a lot of back and forth on how to optimize our studies and the quality of our studies, and certainly CT fusion is essential. I mean, our lab has still been using the 3 hour imaging technique, but like I said, combining and reaching out to as many tools as possible, incorporating them is really essential. So it's a relatively busy lab. They have been comfortable doing the 3 hour images, but I would encourage every lab to move towards using SPECT at a minimum and using CT fusion imaging, because again, even at the 3 hour mark, 31% of patients required CT fusion imaging for further delineation. So definitely that's one thing. And the other thing is a common, relatively, I don't know how common it is outside, but I've seen it in various reports coming from other centers in our region, is that if there is a suspicion or a high grade uptake, the interpretation is that the scan is consistent with ATTR, cardiac amyloidosis, and I caution from such a conclusion because you can only make that a statement after excluding the presence of monoclonal proteins, and the nuclear reader does not have that information. So you should just say that it's consistent with cardiac amyloid rather than implying that it's transthyretin amyloidosis.
I think that's an extremely important point that you make. And again, going back to PYP MENA, there is a room for improvement in performing concurrent plasma cell evaluation with the radionuclide imaging for cardiac amyloid. That was identified as an area for potential improvement in our region. Ammar, one last question. I know we're extending into the next presentation. We did not identify hardware as a potential problem or a potential challenge in the region. A lot of centers have access to SPECT, and a few have access to SPECT CT. Still, we see a poor uptake of SPECT CT when it comes to cardiac amyloid imaging. In your mind, is this just a matter of access to technology, or there's just people getting used to performing the test according to older standards? What are your thoughts?
Yeah, I think, if they get the proper exposure to how they can enhance their reading with CT fusion, that would probably change their perspective. Now, one approach is to use older CT scans if available, rather than using the hybrid camera. So if the lab is not equipped with a hybrid camera, that's an option, that to use fusion imaging from a prior scan. But again, that's not optimal, and I don't think that's a validated approach. So it's better to avoid that. But I think, the more we advocate for CT fusion and the readers actually see how much of a difference it makes, the uptake will be greater.
Fantastic. Okay, I just want to remind everybody that you've tuned in to the Gulf Amyloidosis Club. I would like to thank our sponsor, AstraZeneca, who made a unrestricted grant support for this program through Emirates Cardiac Society. This program could not be possible without their support. And I also want to invite the attendees to submit their questions about this study, or about cardiac or imaging for cardiac amyloid in general. Abdullah, do we have any other questions in the chat that need to be answered?
No, we don't have at the moment.
We don't have any other questions. We have another presenter, Dr. Smiley from Cleveland Clinic, Florida, who unfortunately was called to attend to a sick patient at the moment. We strongly, definitely support her. Patients come first. But if we just maybe ask Dr. Ammar another question, and if she's unable to join us, we may have to have her do her presentation at a later date. She's been spearheading efforts to promote the role of PET, which is another new development in the field of cardiac imaging for amyloid. And Leah has been really at the forefront when it comes to PET imaging for amyloidosis, but unfortunately she was called back to the ward. Ammar, one last question. You've highlighted more than once that this study population may not be entirely representative for the TTR population. They're younger, they have less cardiac remodeling, they're not as sick in terms of biomarker. Do you think what are your thoughts? Do you think the results may have been different if the population was more enriched with TTR patients? What are your thoughts? It's hard to speculate, but what do you think?
It is. But I mean, you need to obviously have a mix of everyone. Cases that are don't end up being positive. You definitely need to enrich your population with that. But if you look at the proportion of patients that were positive, they were still relatively small. So numerically, you have 23% is a relatively small number. You need to have the equivocals, you need to have the negatives for sure to make the appropriate comparison, but it would have been nice if you had like a 50-50 distribution perhaps. What is also interesting is the practice patterns, and the thresholds referring patients for additional imaging, because there could be consequences of an equivocal scan or a false positive or a false negative scan. So if the pretest likelihood is not particularly high, and I'm not sure would you necessarily scan someone with a wall thickness that is normal, just based on the fact that they're elderly and they're male and their cardiomyopathy score is 6. So let's go and scan them. And then you end up with either a false positive or false negative. I'm not sure if that's, would be the right approach. The traditional classic recommendation has been that you need to start off with clinical suspicion. You need to have some degree of left ventricular hypertrophy. But it is paradoxical because those cases tend to be, a little bit late. And if we want to diagnose these patients early because we think they're going to benefit from earlier intervention, then you get into this murky zone of borderline LVH or no LVH, and yeah, it can be a bit messy.
Totally agree. It's a slippery slope.
It's a
Higher
paradox, yeah.
with higher pretest likelihood, then the population will be different.
What is your practice
Okay.
at your center, if I may ask, in terms of the timing and the use of CT fusion imaging as well?
Thank you for this question. In terms of referral, we've had a period of time where our threshold to refer patients for CARI was lower. So there's excitement, there's enthusiasm about making this important life changing diagnosis. So there definitely were patients referred with slight increases in wall thickness, kind of similar to what was done in this study. So the yield on testing was low, and as a result, the pendulum is shifted in the other direction. People kind of now internally need a higher pretest suspicion before they send patients. So as a result, we've seen a reduction in the number of studies, but the proportion of patients who turn positive has gone up. So that's from a patient selection standpoint. When it comes to hardware, almost all of our studies for amyloid are done on a SPECT CT scan. As I told you, 100% are done with PYP, and we do 3-hour imaging. With the thinking that PYP has some different characteristics, that it takes time to clear the blood pool and get to the myocardium. So if you do it at 3 hours, you're more likely to get an answer. If you do more 1 hour, then you're more likely to encounter blood pool and have to re-image them at 3. So we've cut the 1 hour and we've restricted that to the 3 hours. And we use SPECT CT, as I said. Do we run into equivocal studies? Absolutely. We still run into that quite a bit. So the more data is needed and more work is definitely needs to be done. Do you have any other comments or last comments or conclusions you want to make before we wrap this up, Ammar?
No, I certainly, really appreciate the opportunity, and I think the topic selection and the whole activity is really great, and hopefully we'll have more participation from everyone.
Absolutely. It wouldn't be great without participation of colleagues like yourself, Ammar. I would like to thank you. I really cannot thank you enough for your time and diligence dissecting this article and elegantly presenting it. I would like to thank the audience, and I promise you a rain check for Dr. Smiley's presentation. So stay tuned. We'll be back with more presentation. Until then, I would like to thank you all, and we'll be back with another episode of the Gulf Amyloidosis Club. Until then, be safe. Assalamu alaikum.
Wa alaikum salam.